So I'll start the second part of the talk about medication in functional neurological symptoms by telling you about a key drug discovery, key research discovery, which concerns antidepressant use, the so-called antidepressant use. So there was a review that looked at all the studies in which people with functional neurological symptoms were given antidepressants. And it was found that those people that took the medicine were 3 times more likely to improve compared to those who didn't. And the really interesting thing was that this happened whether the patients felt depressed or not. And this here is the article for people who would like to look it up. It's in this journal of family practice, and you'll notice that it was done in 1999. Not much has changed with respect to antidepressants themselves since then, but I would like to note that our rehabilitation treatments have improved since then. Okay, so this may make you think, how could an antidepressant work if the person concerned is not depressed? Because, as I said, antidepressants often help symptoms in people who are not feeling depressed. Well, it seems that antidepressants, so-called antidepressants, have got wider actions than treating low mood. So they can help with pain, with sleep and with appetite, and they can actually, it seems, reverse some of the abnormalities in the chemicals involved in brain function that I mentioned before when I talked about the classes of these antidepressants, and we're going to revisit again in a moment. And what seems to happen is that there are some key relationships between conditions like chronic pain and conditions like low mood and possibly other related brain states. What happens is that pain and depression share brain circuits. There's bits of brain, there's parts of the brain, circuits in the brain that are affected in a similar way across these different conditions. Both pain and depression seem to share pathways both in the brain itself and in the spinal cord. And these key chemicals that are affected by these so-called antidepressant drugs seem to be important for both, and these are serotonin and noradrenaline. And this is a picture from a few years ago again, illustrating that, and what this says is that pain is not only a signal that comes up to the brain through this so-called ascending pathway, but it's actually something which is actively controlled by the brain through this descending pathway, and that these chemicals seem to affect or modulate the pain sensitivity through this descending pathway. Again, this is actually a way of putting it which is the way that it was put back in the very end of the 90s, but it's not a bad way of thinking about it still. So, this is not many of our patients that have got functional neurological symptoms have pain that lasts quite a long time, as you may have already seen in one of the other talks, or you may have experienced it yourself. In many clinical pain conditions, that when the pain lasts a long time, there are these particular parts of the brain that appear affected and become more sensitive, no matter what the underlying condition is, whatever we call it, the underlying pathology is. And these areas are mostly in the front half of the brain. So if you want to think about it in that way, sort of like in front of your ears. And what we find when we do brain scans, for example, is that this chronic pain, which lasts a long time, activates the brain in a different pattern than pain which happens, new pain that happens in, say, for example, a healthy person that experiences an injury. And this is another article that reviews this for anyone who may actually want to look into the technical side of it. Now, what we find is that similar patterns of brain activity are found in several other conditions, such as anxiety states, depression, but then more physical conditions like irritable bowel syndrome, chronic fatigue, fibromyalgia, somatization, and even fear, which is obviously quite different from the others. And if we were to hazard a guess to try and make some sense of this, one way of seeing it is that pain corresponds to a warning signal or a prediction that says that there is impending damage to the body. And if you look at these various conditions, they may also have this twist to them. What I'm saying here is a little bit of a theory, but I think it helps to make sense of what's going on. And this actually is useful in linking the pain that we have looked at as something that occurs in the brain, and which is actually changed itself. The brain is changed itself by pain that lasts a long time, to the types of thinking that we have actually talked about in other areas in this 5 areas approach. You can think that if pain, and in particular chronic pain here, is about making a prediction that there is impending damage, this sort of prediction may trigger increased anxiety, worried thoughts, avoidance behaviors, and possibly even an increase in pain if you have an increased stress response, an increased muscle tension, and so on, that we've talked about in previous sessions.